Thank you very much, Aditi, and thank you for the invitation to join you at the MSF Scientific Days Asia 2021. So I have the privilege of chairing this session on person-centered care, and it's a session which looks at some of the lessons and challenges of implementing person-centered care based on experiences within the Asia region. Now, whether we talk about person-centered or people-centered or patient-centered, and there are nuances, some nuanced differences, when we distill these down to the practical implications for implementation, they all have several things in common. There is firstly the element of listening, care that makes explicit the importance of listening to the needs, wishes, and concerns of the patient, seeing the person behind the patient. There's an element of understanding, ensuring health actors understand the health context, the social realities, and the values in those communities, and that this understanding informs programming. There is the element of adapted service design, services that are designed with or organized around the needs of individual patients and communities. And there's the element of accountability to communities. And often this also means using or learning from patient experience and community feedback to inform service delivery. And these are elements that I think we'll see highlighted in some of the presentations today. Now, before we start, I wanted to just highlight a couple of points about why it's important for humanitarian agencies such as MSF to be talking about this. Now, the first reason is that the existing literature and guidance on person-centered care in global health says relatively little about implementing this in humanitarian emergencies. We may wish for a fully participative design process based on a real relationship between health provider and community, but sometimes the urgency of the response inhibits us from achieving that to the extent we would like to. And yet, even in the direst emergency, can we find some means to communicate with people that builds agency rather than depletes it? And this is a challenge for humanitarian agencies when thinking about person-centered care. The second point to highlight is that MSF and many other agencies are looking to implement person-centered care at a time that global health actors are also needing to address the colonial aid system legacy. So historically, decision-making is based where funding comes from as opposed to where programs are. This extremely imbalanced power relationship between the provider and the community, which in the case of medical actors is even more so because of the paternalistic medical model. All of this seems to go in the opposite direction from shared decision-making with patients. So becoming more patient-centered or person-centered may require quite some systemic change within global health and humanitarian actors. And finally, the point I wanted to raise was contextualizing, the challenge of contextualizing person-centered care. Now, this doesn't only apply in humanitarian settings, in global health settings in general. The diversity of settings with varied practices, attitudes regarding individual agency, gender roles, etc. We must acknowledge that we're working in such a diversity of settings, and yet the modern conception of person-centered care that is described in the WHO literature is based on a particular intellectual tradition and quite informed by the work of Carl Rogers in the 70s. And we may have our own or our institutional aspirations about the type of care we want to deliver, but this might be quite impractical in some of the contexts we work. So if in a particular context, patients may not expect to be asked their opinion, or a woman may expect a male to consent on her behalf, what will contextualizing person-centered care mean in those contexts? And it may mean that then we need to look for the common ground behind that WHO ideal of person-centered care, the wishes of those we are trying to assist, and the practices and systems of authority in place in that context.